ขึ้นไม่ทัน
Right. Perhaps if that's me or if that's someone else. Okay. Gone away. Right. Is any of those people at Glenfield? I can't tell. The cameras up. Might just start anyway. Okay. Hello, everybody. I haven't met all of you yet because we've only started this week. I am Zoe. I'm one of the ICU consultants. I'm going to talk about referrals to ICU because hopefully, well, some of you will know it. Some of it will be quite useful, I hope, and give you a bit of an idea of how to structure it. The aim is to try and work out how to approach a referral, what we're looking for, and then have a bit of a practice about decision making, which will probably demonstrate, as what happened last time was that everybody has a different opinion and there's no single answer to whether to admit somebody to ICU or not, basically. And it's quite interactive, so please go on your phones, sign into see the QR code, or just go to mentor.com and put the code in, whichever you prefer. And I can't see who's voted what, so don't feel worried about it or scared about it. I won't judge any of you. No, I can't see names. So you're okay. All right. Are we sorted? You'll be able to see the code anyway. So the principles of ICU admission basically is the 4 pillars of ethics. We try and do what's best for each individual person, and sometimes a bit of justice comes into it as well, to try and do the best for the most people, which is where the rationing thing comes along. We try not to let that affect decision making, but sometimes it probably does, even if it does it unconsciously. So, if you look at what you clicked on the device, what do you think is important about when you're deciding whether to admit somebody to ICU or not? Are these things very important or not important at all? And it will change as people vote, so you'll be able to see what people think.
We just slide the things across and
yeah.
You click them.
People seem to think that what the patient wants is more important than what the referring specialty wants, which is probably a good thing.
When you say is it worth it, does that mean as well?
Is ICU admission worth it to the patient? Okay. Are they going to get something out of it? Most people seem to think it's quite important to have a diagnosis, which we don't always have in ICU. I would say we can support organs without knowing why they don't work. Sometimes it is helpful to know what the diagnosis is, but we don't necessarily know. And yeah, we're not supposed to make decisions about whether, like I said, whether it depends. We're not supposed to decide on whether to admit somebody because we've got an empty bed or not. It does interfere with it a little bit, I think, as to whether we do. But we're not supposed to make decisions. We quite often will admit somebody and then have to work it out how we're going to look after them afterwards. So when we get a referral, these are the 3 questions that are in my head as to whether they get admitted or not. And I'll go through each one individually. So the first one, do they actually need organ support? If they don't need organ support, then they don't need to come to ICU. So that might be airway, because nobody else does that. Or it might be respiratory, they need to go on a ventilator because they're in respiratory failure. Or they are need vasopressors or inotropes because their heart doesn't work, or the blood pressure is too low, which is probably one of the most common reasons. No GCS for the airway kind of comes into the brain problem, which might be to do with drugs or seizures, or whether they've had a brain injury, and then you might need to prognosticate over the next few days as to whether they're going to survive their brain injury or not. Monitoring is the only one that's not really organ support, but sometimes they need watching more than they can do on a normal ward. The classic one that we get all the time here about that would be the DKA patients who need blood tests all the time, I guess. Especially if they're a bit dozy and aren't really safe to be left on a ward because they're too unconscious, but hopefully you don't want to intubate them because of their cushion breathing to compensate for their pH. We can't ventilate them hard enough, so we don't want to intubate them, but we can watch them and they wake up as their pH improves, is the idea. And then metabolic stuff and acidosis and renal failure and things. So they're fairly straightforward to work out whether somebody needs organ support or not. And if they don't need any of those things, if their blood pressure's got better with fluid, then they don't need to come to ICU. That's quite straightforward, I think. The next question is it a reversible condition? Which sometimes is harder to work out than it should be, but is it an infection? You can treat the source. Is it a bleed, whether that's a traumatic bleed, an obstetric one, an operation, or a variceal bleed? We get quite a lot of. The only question for those is, do they need to be somewhere to stop the bleeding before they come, and they come to us for management of their massive transfusion complications afterwards? Trauma, so physical injuries, brain injury, cardiac arrest type people, they come. Have they taken some drugs acutely that are either had intoxicating effects or having side effects? Or have they got an exacerbation of an existing condition, whether that's COPD or liver failure or something? And is that treatable? This is where the question comes. Or is it an expected deterioration of their worsening underlying disease, which is not going to get better? So the end stage COPD or the end stage liver disease, we might not admit them because it's kind of the end of their disease process rather than it being a reversible thing, which is sometimes harder to work out, but that's the other thing to do. And then a final question is, have they got the functional reserve to recover from their illness and to survive their ICU stay? Because although they're just lying in bed, it's actually extremely hard work for the body to survive their catabolic state and then to recover from vaguely back to where they were before. It takes weeks and months. So need to work out what they can do before they come to hospital. Are they fairly active? Are they able to walk about? Do they? If you say, can you walk about? And they say yes, and then you say, do you actually walk about, or do you sit and watch TV all day? Work out, let's put prognosis, whether they've got, for cancer patients, sometimes you might want to know what kind of is their expected prognosis for their cancer. Is it going to be 2 months or is it several years? And whether they're going to be able to get back to any sort of decent quality of life that would be acceptable to them. Are they going to be able to be independent, or are they going to be in bed being fed? And that's where frailty is quite important. If they are frail, they're not going to get back to a decent state probably. Are there any other options that are more acceptable or less invasive? So non-surgical, maybe doing a percutaneous drain for an abscess rather than a tracheotomy. Or do they want to go home? And part of it is, what do the patient, sometimes you go and see a patient and you say, this is what we can do, and they go, oh thanks. That makes it a whole lot easier. Just have to be realistic and explain to them what the, how hard it is going to be, basically. Right. So there's the 3 questions and the various bits that we need to think about whenever you go and see a patient or who's been referred to ICU. These are the things that you kind of need to think about and trying to work out what the answers to those are, to work out what your decision is, whether you're going to ring, when you're going to ring the consultant, and what you're going to say to them as to who you're going to admit. So I've got some examples for you. So you get a phone call got a patient downstairs with GCS of 5 in resus. Come down now and provide all the support. Are you going to go straight down, or are you going to ask for more information? Right. Okay, so to get some more information. First one, you've got a 24-year-old lady who's taken an overdose of antidepressants and alcohol and has a GCS of 5. Okay. So, what are you going to do with her? Yeah. I mean, yeah, most people will reassess GCS when they go back down. None of these are the wrong answer, I don't think. You can usually make their GCS better by giving them proper stimulus, because you can usually make it better, like 1 or 2 better than ED can by pressing really hard. And if it depends, if she came in with a GCS of 3 and it's getting better and she seems to be fine, then you could just watch for a bit and see if it continues to get better, and hopefully that will wake up. It depends a bit what she's taken. If she's taken a bit of paracetamol and a load of alcohol, then she's probably mostly drunk. You can just watch it. If she's taken a load of benzos or something, then she'll probably not going to wake up for quite a long time and might need a bit more support. The trends of what the GCS are actually more important than the actual number, probably.
I would caution on, a young person with a potential significantly below 7.
Yeah. There's no reason not to intubate.
Particularly with a very reversible cause and good prognosis, early intubation probably would be the direction of travel.
Yeah, probably. There's no reason not to.
No. I mean, I've taken the nuances there about what direction of travel are they improving, what's the sort of pharmacology of what they're taking, but yeah.
Oh, okay, next one. Okay. The patient needs a CT scan. Are you going to intubate them and take the CT scan, or are you going to escort them to CT scan without a tube? Fairly even split. Sorry? Yeah. You could do either. It depends a bit what you are most comfortable with. You just need to, and if you're not comfortable taking someone on even a very short transfer without a tube, then that's fine. You just need to remember that you're going to be careful. You need to be comfortable with what you're going to do next, as to what the CT scan shows.
What's the rationale for the latter, for the escort CT without a tube? What would the rationale for that?
Not wanting to do it because you can't be bothered.
Yeah.
If you can't be bothered, that's a separate thing that probably needs investigating.
Well, six people said that. I'm not asking if you say what you said, why you said it, but what would be the rationale for the right side answer?
So if it was me, I would do say that I would intubate them. But if I felt that their airway was vomiting, and the chances of them vomiting were low, and I was profoundly confident that I could just shove a tube in CT, then perhaps one could choose that option. But I do think it is much. I would intubate them and take a CT, because you can never second guess in neurosurgeons, because what that implies is, they're going to say no, it doesn't matter what's in their head, but that is not the case.
Well, it implies that you're guessing the problem.
Yeah.
You've made your mind up about prognosis, and you don't want to intubate a patient in it, because it's much easier not to intubate to extubate.
Yeah, that's what I said.
You kind of hedging.
If you're comfortable with extubating them in
You're hedging your bets. You're not going to escalate on this person.
Yeah.
What are you actually doing there?
But you can't be sure of that because you've not consulted anyone else according to the
Okay. So you've got a massive bleeding on CT scan and the neurosurgeon say no. What are you going to do now? Are you going to admit them to ICU? Are you going to palliate in admit them to ICU for prognostication, or palliate in ED, or admit them to ICU and palliate them up there? It's pink and blue because it depends on what you said to the answer to the first question. So if you said you tube them, then it's blue. If you said you take them without a tube, then it's pink. And most people have said palliate in ED. A couple of the people that have said that they tube them have said they'll bring them upstairs and then prognosticate or palliate. The guidelines for the devastating brain injury thing say if it's somebody that you would, if they've got a devastating brain injury and it's somebody that you would otherwise admit to ICU, then you probably should admit them to prognosticate properly and give neuroprotection for some up to 72 hours and then prognosticate properly. If this one's older and frail, and you might not admit them to ITU, then you can potentially palliate them in ED. It depends a bit as to what ED is like and whether you're comfortable palliating upstairs a bit or not. Whether you've got, although you're not supposed to, I said it already, you're not supposed to make decisions on that. If you've got the space to palliate upstairs, then it's generally nicer to palliate up here than it is in ED anyway.
Unless you've got a bedside nurse who's going to provide actual palliative care, it's pretty grim.
It is pretty grim.
ED cannot provide that care.
And what you're doing there is extended care to family, aren't you?
Yeah, it's giving the family time.
Giving family time upstairs.
How you get here, we'll just sit with them.
I think increasingly I see we do play a part in life care. We do it better probably because of our staffing. We're not intrinsically better, but I think that is a reason. And what's the only other reason you might admit someone in that condition to ICU, or other reason?
Is it really dependent on how the family is taking on the situation?
Yeah, no, I think part of our duty of care is the family, definitely. There's only one other reason, and that would be if you're considering any form of organ donation, which in an 85-year-old, they might, but it's just, that's never in the patient's necessarily best interest of having their autonomy. But it's just another.
Get to organ donation, don't worry.
Hello. Yeah, not bad.
Yeah, the same GCS, just a variety of the different things that you might get. So this is probably a predictable diagnosis, to be honest. Same as before. Would you intubate them or and take them to CT or not? Yeah, so everybody this time would intubate them. I think it still needs to be comfortable with what you're going to do next, and can you potentially make their prognosis a bit better by neuroprotecting them? Maybe. So I think tubing them is a reasonable thing to do. Okay, so this one, the CT shows a large subarachnoid hemorrhage with some extension and a bit of herniation. So again, the neurosurgeons say no because it's too big and there's nothing they can do about it. So for this one, what you're going to do, again, it changes colour slightly. So everybody picked intubate last one, so they'll all be the same colour. So you're going to admit them to ITU for prognostication or organ donation or palliate in ED or palliate upstairs. Yeah, both. To be honest, I suspect that it could be admit for prognostication, or it could be admit for palliation, or it could be admit for organ donation. They're all the same thing in this situation, I suspect. You're going to prognosticate first, and if it becomes clear they're going to die, then you might come to the organ donation thing. But yeah, I think prognosticate properly. So this patient would get 72 hours of decent neuroprotection and then have a look, probably a re-CT, maybe an EEG, see what they are like clinically, unless they develop signs of brainstem death within that. Okay. Different problem, not GCS anymore. You've got somebody with sepsis, basically. Still hypotensive despite getting some fluid and still a bit acidotic. Which you probably, even though you've only been on ITU for 2 days, some of you, it's probably figured out that happens already. Do the numbers on the blood gas actually help you make a decision, do you think? They don't help if you read them to me at 3 in the morning when you've just woken me up, because I'm not going to take them in. Do you think they've had enough fluid yet? Yeah? Really enough to see whether they're going to make some sort of response? Okay, so what are you going to do? Admit them to ICU? Admit them to ICU for limited support? Or don't admit them? Yeah, this is a very reversible condition, isn't it? With the right support and the right treatment, it should get better. We should probably bring them in and do what we can. Okay, so the treatment required. What do you think of these 5 things? Obviously, all of them are going to potentially be useful. Which one do you think is going to make the difference? What is going to make her better? I quite like it real time. It kind of all switches and you can see what people are thinking. It's quite fun. Right. All right. So yeah, all of these things are important, and you might do all of them. It depends whether she's peeing or not, but if she's really acidotic and it's not getting better, then you might do renal pressure therapy. You brought her up probably to give vasopressors, which obviously she won't get antibiotic. But the thing that's going to make her better is source control. It's the same, it's why it's in the sepsis pathway. You've got your sepsis 6, but you've also got source control, which is what people tend to forget about. So even if it's the middle of the night, you need interventional radiology to come in and put a nephrostomy in. Because she's got sepsis. You should do, and they will come in if you ask them to. They're usually not too big. Okay. So you want a bit more Glenfieldy. Somebody's had an out-hospital cardiac arrest. 25 minutes is not too long a time, I guess. Cardiology wants to take him to cath lab. It comes through as a STEMI alert. So, what are you going to do? You're going to take him to cath lab? You're going to admit him to ITU? You're going to change to a tube? You're going to give him a sedation? You're going to hang around to sort out, to put an article in? Or are you going to decide, like Fran said, you're going to decide you can't be bothered and do nothing about it? Hopefully nobody says that.
Do these have to be 1, 2, 3, and 4 and 5, or is it you can rank them?
You can rank them.
Yeah.
You can. I think you can score them as to how much you want to do. I don't remember. Yeah. That's good, because that's what I kind of wanted people to say. So yeah, take him to cath lab, probably admit him to ITU afterwards. At some point, change the IGR for a tube, but if it's working, it's probably not the biggest priority. It's quicker. It's more important to get into cath lab. So at least started, probably, to try and save as much myocardium as you can. A bit of sedation, particularly if he's stressed and wriggling around or getting a bit hypertensive. And yeah, I probably wouldn't wait or say that they can't start while I get an outline in, to be honest. If they're really hypotensive, then maybe I would, but you can either try and do it during or just do it afterwards, I suspect. Is that what they still do at Glenpool?
I think so, yeah, I don't think
They
Just get on and do it.
Up to trace off of the catheter anyway.
Yeah. Yeah, true. So once the traces in the catheter. No, line's not going to change outcome. So it's just get on with it. So it's similar to doing a trauma transfer to Nottingham. Just get them somewhere where they need to go rather than hang around and put any lines in. It's not going to change it. If you're waiting for the ambulance, then fine, get on and do it, but don't everybody else wait for a line. Okay. So a different out of hospital cardiac arrest, older person, PA, shorter time though. Got G53 and got distended tummy. Got some comorbidities. Again, get called from ED this time. So, what are you going to do with him? You think he's got a AAA? You're going to take him to theatre?
straight to Longfield.
Going to palliate in ICU, palliate in ED, or do anything else?
That's which hospital.
Maybe it depends which hospital you're in. If you're in somewhere that's got a vascular, then it might change what you do a little bit, but not that much. Yeah, I think talking to the family is a useful thing to do potentially. Yeah. So again, most people think he's probably going to die. If he has got a ruptured AAA, then he probably is after he's already arrested, to be honest. Cool. Like I said, there's no straight answer to most of it. When I was looking at it yesterday, having done this before, I couldn't actually remember what my answers were to some of these ones. Okay. You've got an alcoholic who's still drinking, who's come in with a variceal bleed, and needs an OGG and theatre under a GA. Why is the still drinking important?
Liver transplant.
Yeah. So if you're still drinking, you can't go on a liver transplant list, basically. So would you admit him or not? Or would you be limited about it? And the limit might be variable. It might be, I'm not going to filter him, or it might be, I'll do full support for 48 hours. Cool. So most people, everybody would admit him. A variceal bleed is a reversible cause. If they can stop the bleeding, then it can be quite, it is reversible. So yeah, I think most of us will probably admit them for 48 hours and give full support and see. And if we can't stop the bleeding, then it becomes a different thing. Or if they develop renal failure afterwards, I think it's more of a discussion sometimes with the straight off.
In these difficult ones, the important concept is the idea of admission to assess responsiveness to treatment. So in some countries with units with unlimited resources, and there's probably no such thing as unlimited, but they often do have an open door policy, and you base your withdrawal for implementation on response to treatment, which is quite a nice thing to be able to do, isn't it?
Yeah. It is. Okay. Same guy. But a week or so later, now he's septic and he's hypotensive with a lactate of 8. He's a bit dozy. They've given him fluid, but he's still hypotensive and drowsy. So probably encephalopathic. Been in hospital for a week or two. Not really very mobile. Not been that well on the ward. What do you think now? got an infection, basically. Do the name or not, basically. I like that nobody knows.
That's underlying under limited.
Yeah. So
Oh, yeah, it's bottles.
this is nobody knows to use this for antibiotics.
Well, something.
Um,
If you want to give them all time or not.
So how reversible is this? Maybe, I mean, it probably is a little bit reversible, but maybe a bit less so than.
We can have an episode of SVP, could potentially treat that.
Yeah, maybe he's got SVP, maybe he's got a bit of a hospital-acquired pneumonia or something relatively straightforward.
They've been aggressively treating and investigating, and he's deteriorated despite that. I think he'd be reluctant then.
Yeah.
But if he's just deteriorated 24 hours, potentially irreversible.
And his other organ dysfunction, if he was on 7% oxygen, deteriorating renal function, you'd add the whole picture up, wouldn't you? And you probably wouldn't admit him multi-organ dysfunction on the background of that.
No, if he's just hypotensive and you might maybe
Yeah,
a little bit of
yeah.
vasopressor, it's not such a bad thing to do. But yeah, I don't know, I think I'd be a little bit more uninterested in doing everything. Not uninterested, disinclined.
Because there's a lot of, with the ACLFs, there's a lot of good evidence that's revealed to the years ago, didn't we? So say we, not you and me particularly.
It wasn't me, I didn't do that one.
In ratio, we found that two organ, probably we are pessimistic, overly pessimistic in the less well, if that makes sense. So single and even two organ failure, so that's say respiratory failure and hypertension in ACLF patients do reasonably well. It's as soon as you hit three organ failure, and particularly renal failure on top of it, then mortality in ICU is right up there, 90% plus. I don't think much has changed since we did that 10 years ago, probably.
Probably not. Okay. Different one then. Oh, in the background of heart failure. Needs a lot of help, not got a very good exercise clearance. But heart failure and COPD. Yes. Not needing much oxygen right now, but some sensible medic has said it's 3 o'clock in the afternoon, why don't we make a decision about this now rather than at 3 AM, which is always nice. It's better to sort it out in the daytime because you can talk to the family, you can have a discussion with colleagues, you can talk to the medics about it. Do you feel that the medical consultant can make this decision by themselves? I'm not looking accusingly at the medics in the room. Some of them will, some of them won't. Okay, so what do you think? Would you give invasive ICU support? Or would you give NIV on ICU? Or would you give just NIV? I mean, it might depend a little bit which hospital you're in, because if you're doing NIV at the Glenfield on the wards, it's different to doing NIV on ACU down here because it's more effective on respiratory wards, I think, because they're much more used to doing it. Well, that was a whole lot more emphatic than it was with our first fine. Yeah, so the reversibility of this is very questionable, isn't it? It just seems as though they're in the terminal decline of their COPD. So probably invasive ventilation is not appropriate. And yeah, I probably wouldn't bring them up here, to be honest.
And there's always been this argument in terms of non-invasive support. If you're going to escalate, but a non-invasive support may help to avoid escalation, bring them to ICU, so you're in the right place to escalate. If that's the absolute ceiling, there's an argument to say keep them on a ward base. I totally agree with Zoe. The problem we've got here, ACB is the only place we can do it. Whereas, you know, in Glenfield, CCU doing IB, I think
CCU.
and constant respiratory wards. So my general rule is, if I'm not going to escalate, and this is definitely the ceiling, I tend to say ward-based care.
Yeah, although I have admitted people in the past.
Me too.
Who have, I remember admitting somebody who, in COVID actually, who we weren't going to intubate him, but he was he just felt like he wasn't getting enough air. So he ended up coming up so that he could have a high flow oxygen, because he could put the 15 litres through the nipping machine. What just wasn't enough.
No. And the other big advantage.
And that did actually really got better.
Yeah, they can't.
Yeah, we
use
can
the
put it on.
outlines, which is nice for the patient, not to be stabbed over. Gases.
Okay, changing tack slightly, different, go to neurology. So somebody who got a diagnosis with Guillain-Barré syndrome, the neurologists have already made that decision and are happy with their diagnosis. Getting a little bit worse. They've been monitoring their forced vital capacity, as they do. It's 1.1 at the minute. He's not got any autoimmune features. So when are you going to admit somebody to ICU with Guillain-Barré syndrome, basically? Is it everybody has a low FVC? Or is it somebody who's got difficulties swallowing, so kind of older symptoms? Or if they need some oxygen? Do they need automatically need consenting for a tracheostomy, do you think? Before you intubate them? The thing about FVC, I think you need to generally, if they've got a consistently low FVC, then they probably do need to come. The thing that happens is it gets done at 2 AM and it's low. So get somebody to do it who actually knows how to do it would be my answer, rather than just being a one-off when it's been fine all the time. Yeah, bulbar symptoms are concerning.
Sometimes the nurses quite often they ask like every half an hour, do they facing on the patient?
And it's usually
They kind of get
badly
bored,
done by
yeah.
someone who doesn't know how to do it, i.e. not the patient, but the nurse or someone doing it. The physios are good at it. I think if you're going to base it on true FTC, you need to go do it yourself.
Yeah.
Last week I got one with the FTC of 0.45.
Yeah.
And he was not for intensive care in the ECT. And then eventually when I asked him to do it, after giving the rest of 2 hours, it was 1.6. So
You can usually change their FVC by doing it properly. And yeah, I usually talk to them about tracheostomy before tubing them for the Guillain-Barré ones, unless you're doing it in an emergency, but you shouldn't be, because we should already know about it and be reviewing them regularly. But yeah, there's a lot of debate about early versus late trachea, and it doesn't really show that much. But if you always do early trachees, then you're probably going to do more trachees than you need. But I think Guillain-Barré syndrome is actually a good one when they do benefit from an early one, because they are going to need it and they might as well be awake a lot of the time.
So they said they didn't want tracking when you're in your consenting process. Well, how would that go down as they're not getting a tracking? If they're poorly.
I've never come across that.
It's nice to talk about it.
You'd want to know why. Do they actually want intubation in an ICU stay? Because you can't really do one without the other.
I guess you'd have to, if they've got capacity at that point, you have to respect it. What I would back my money on is that once they've had a few days intubated at half a weight with a tube down, you say, look, you're going to be like this for 3 months, male, maybe not 3 months, but 3 weeks, they'll probably go get on track. Is that informed consent, or they don't really know what they're letting themselves in for?
Yeah, true. Okay. So hematology patient, quite hypoxic and needing lots of oxygen, otherwise independent and well, has got mantle cell lymphoma with some really style disease. I think this is the one I couldn't remember what I put the answer to.
Sounds very real.
Yeah, no. We get this sort of thing relatively often. So you go and review them. A bit more information. So they are working a bit moderately hard, are independent, but not been doing as much recently. probably since diagnosis and chemo and stuff. From the hematology side, it's their mantle cell lymphoma is chemo resistant and it's rapidly progressive mediastinal disease. Apparently. What do you think about reversibility?
You're resistant, doesn't sound good.
Doesn't sound great, does it? Okay. So what do you think? Are you going to admit them or not? This is for respiratory failure, getting hypoxic. Yeah, you probably do need more information. So this is when talking to the hematologist is really helpful. And they go, is there any other option? Because if you can't, if they're hypoxic because of progressive mediastinal disease, they are a bit screwed if there isn't another option. Because it's not going to go away.
The thing with modern hematology, you can't just label a disease and get a prognosis. The hematologist is going to do histochemistry and all markers, and you've got to have a discussion with the relevant and specialist hematologist.
And most of the hematologists are perfectly ready to have a sensible conversation about whether what support to give and how much support to give, which is quite useful, I think. I remember, I don't know if you remember, when I was an SHO, probably not. There was somebody who came from hematology with the same thing, had a big just subcarinal lymph node that was compressing his carina. And he came and had CPAP, and we transferred him from ICU to radiotherapy in the Osborne building. And you have to take the oxygen off for radiotherapy. So we'd have to turn the oxygen off, and he was on a lot. He was on like 50 litres a minute. It went through so many cylinders in that transfer, and we'd have to turn it off, leg it out of the really long, windy corridor to get out of the radiotherapy bit, zap him, and then leg it back in when he was a bit blue. Turn it back on again. It was stressful. Okay. Oh yeah, so a bit of multi-organ failure, so pneumonia, kidney injury, had an STEMI associated with his illness, requiring a decent amount of oxygen and a decent amount of pressure, down on ACB or on the respiratory ward, whichever you prefer, as to which hospital you're in. Hasn't got the best background, it's all a bit cardiac-y. Is there anything else you want to know? I'm showing him. You want to know what his functional reserve is really. It's not great, and he's in multi-organ failure. She is in.
His wishes.
Yeah, the wishes will be useful. Yeah, he's going to end up on. She is going to end up on everything, isn't she? That's probably.
We might talk about Zoe, but increasingly now, of course, particularly with a patient like that, may not have capacity. It's more what the family is saying, and they're using legal sort of confrontation or potential further down the line if you practically go against the family's wishes. That's probably a whole talk itself.
Yeah, I haven't done that one. so as you said, Anthony, she's going to need all of it, which is potentially going to be meaning that having a meaningful recovery, she might recover but actually be in a nursing home and unable to walk and feed herself and stuff. So maybe we'll get base care would be her ceiling, to be honest, if her functional reserve is really that crap. Okay. She wants full escalation. Would it change your mind?
They've got a wedding they want to go to.
Usually a reason. Some people have said yes. The thing to remember is you don't have to offer anything treatment-wise if you don't think it's going to work. You don't have to take in what they say. You still have to talk to them, but you don't have to do what just because they want it. You don't necessarily have to. Okay. This is based on a real case. This was a consultant actually in my first 6 months, I think. So 22-year-old non-verbal cerebral palsy, voice transfer. She could communicate with facial expressions but didn't actually use words. And came in with a chest infection on a reasonable amount of oxygen. Everything else worked, but the lungs didn't work. So how do you think you're going to approach this one?
Detailed discussion with the family.
Yeah, just talking
History over the last few years.
talking to mum.
Yeah, so it's about assessing expectations in this early stage.
Definitely.
These can be some of the most difficult cases you face.
Yes, yeah, can be really difficult. And it's going to become more of a thing, I suspect, as recovery and PICU gets. The kids are living longer, basically.
After the birth, there's a comment of NMUs. I remember Doug Turner. NMUs came about in the 80s, and the prediction from some skeptics was we'd have an ICU 20 years from then, so 2000-ish, should have been inundated with kids with cerebral palsy, and it hasn't happened. So I think there is probably a lot more sensible decision making going on than we realise. We get the odd one, but it's not that common.
No, it's not. No, it's not. So yes, nicely split. You were talking. So yes, it is potentially reversible cause. One that she's probably had many times before. A lot of the children with cerebral palsy will come in and be ventilated for a month every year in the winter. And they've survived all of those to get to adulthood. So sometimes parents will go, well, what's the difference? You do the same thing that you've always done. And this patient's not actually needing ICU right now, so you can make a decision in daylight hours and talk to the family and work out what you want to do. And work out what's tolerable for the patient. Would she tolerate a tracheostomy? That's a question for mum, because you're not going to know the answer. She might not know the answer. So yeah, it's about shared decision making, I think, and working out what mum's expectations are and what you can do about it.
The difference with these for me is that parent will have been essentially the carer of their that child's entire life. Mum and dad have been carers.
Yeah.
If you just blast in and go, oh my God, quality of life, peg fed in a bed, that is an appalling sort of negation of what they've been doing for 22 years. And you've got to be very mindful that the quality of life for them, they will have a rapport, they'll have an emotional connection with that child, or now adults. And if you go in and say this is horrible and hopeless, you're negating everything they've done for 22 years. So it's really tricky stuff.
It's not a way to start a relationship. When I had this one, actually, while I was talking to the mum, the learning disabilities nurse just rocked up randomly. And she was actually really helpful because she was able to support mum from kind of a non-medical side and explain a bit what I was talking about and we were able to work out between the three of us as to what to do. And mum didn't think that she should come to ITU, so she stayed down on ICB.
The other thing, just because they say they were put on the ventilator 3 or 4 times in the last few years and got off it, doesn't mean that was the right thing to do on those occasions.
No, it doesn't.
Might be basically torture for that if you can't.
Yeah, the child can't, the person can't say no because they can't move and talk and communicate. They can't say no, can they? So it is down to what the people that know them think will be the right thing to do. Cool. That's all my cases. So basically, ask 3 questions about each referral, whether they need organ support, whether it's reversible, whether they can survive it and get better. And use the patient and family and treating clinicians to help you find the answers to all of those. The trends are more important than absolute numbers. The trends in GCS or FBC, if you've got Guillain-Barré or whatever, are more important than the numbers, especially when you're ringing the consultant and been woken them off at 3 AM because we won't take the numbers in if you read us a blog cast. And I hope I've demonstrated that not one person doesn't know one of the answers. We've all come up with different answers to it. So don't expect to always know the right thing to do, and ask other people, ask colleagues, ask the nurses on the unit if they've got experience. Doesn't really matter, just ask for opinions. We do it all the time. You don't see us do it, but we do it quite often. Yeah. Hopefully that was relatively interesting and helpful. Does anybody have any questions about referrals and how you make decisions and stuff? No? That makes sense? Maybe? Let me share my other screen. Maybe the feedback sign. Okay. So if you don't have any questions, then it's a short and sweet one, and you can all run off back to work. Didn't do journal club this week because it's the first week, and yeah, wasn't organised enough basically. Thanks, guys. Have a good weekend.
Thanks, Zoe.
All right. Thank you for
I'm
joining me.
looking at the data.
You guys don't need this anymore.